I gotta find them. All right, we are going to start respiratory. All right. Always starting off with notes from Nancy. Never withhold oxygen therapy from any patient with respiratory disease, even, parentheses, or especially a patient with COPD, never withhold oxygen. All right. Now that is a global broad statement. I want you guys to start utilizing your own type of clinical intuition when you're assessing your patients who have COPD and you need to administer O2 for. Especially on your exams, you're always going to get the test question that's describing a COPD patient, and one of the answers is going to be whether or not you need to give them O2. All right. As a very simplistic form of the answer, it would be never withhold oxygen from anybody who needs it. All right. If your patient is presenting dyspneic and they're hypoxic, and or you want to give them O2, you never withhold it. All right. It's giving a COPD patient O2 for the prolonged periods of time, which starts you start to run into problems. Remember from going into pathophys, your COPD patients, classic test question, what drive do they normally use to breathe?
The CO2.
Well, what's the term? You're taking the hypoxic drive, right? We got our normal CO2 drive, which is what drives us to breathe, right? I'm talking, and as I'm talking, I'm not blowing out CO2. My CO2 levels start to rise, which is one of the mechanisms is triggering me to take a breath, right? Which is going to blow out the CO2 and maintain homeostasis within my CO2. As far as your COPD patients, they don't rely on that anymore. They rely on this hypoxic drive, quote, all right? In which they rely on a classically low oxygen saturation levels to breathe, right? So a COPD patient is not uncommon to be sitting at 88%, 92%, which is normal, which if you put an O2 sat on me and I read 92%, you'd be like, this guy needs some O2. As far as a COPD patient, that might be normal for them. But on the flip side of that, if you run on a COPD patient who's puffing away, using accessory muscles to breathe, they are appearing blue and cyanotic, and their O2 sats are 86, 88%, do you ever withhold O2 from them? No, you don't. Right? You're not going to run into trouble in the short term giving these patients oxygen. All right? It's not until hours to maybe even days in some literature where that O2 that you give them is going to knock off their respiratory drive. Right? But in the acute setting, which is what we deal with, don't ever withhold O2 from somebody who you suspect needs it.
Now, do you put them on a non-breather or a cannula?
Depending on your clinical protocol. All right, there are some protocols out there that say put your COPD patients on a cannula. All right, but if my patient is huffing and puffing, I'm going to put them on a non-rebreather mask. It's just what I'm going to do. All right, and you can PubMed search, you can literature search this all day long, and there's two trains of thoughts. But as of today, paramedics will never withhold O2 from anybody who needs it. All right. So as far as just kind of a review of our respiratory anatomy, we call it the bronchial tree because it ironically looks like a tree that's inverted. All right. Remember, we have our trachea, then we have our left to right main stem bronchus, breaks into our bronchioles, which terminates at our alveolus. Plural would be alveoli. And circling the alveoli are capillary networks that oxygen and CO2 exchange take place. Remember, diffusion can only happen through a capillary, nothing else. It can only happen through a capillary because it lacks what, Danny? Why can diffusion happen only through a capillary? Because it lacks the tunic media, all right? Because it lacks that, so diffusion can only happen through that. We know what nares are. We know what the mouth is. We know what the oropharynx is. Oropharynx and nasopharynx meet to form the pharynx. We know what the glottis is. We know what the larynx looks like. Remember that from anatomy. Your arytenoid cartilages, your arytenoid notch. Always looking for that when you're looking for your glottic opening when intubating a patient. We know our cricoid cartilage and we know our cricothyroid membrane. And why is the cricothyroid membrane important for us?
It's for the cric as one.
That's the most important, right?
Yeah, for the cric.
Yeah. That's our landmark for doing crics. So we have to be familiar with where that is and how to assess for it and how to find it. That's one thing we'll do in lab today. All right. Now, our lower airway, we're talking about bronchi. We already talked about that. Our bronchial tree is lined with smooth muscle epithelium that contains receptors that control bronchorelaxation and bronchoconstriction. We have our alveolus, and what is our surfactant? What is that?
That's the fluid around each alveoli that keep the alveoli open.
Correct. Produced from S1 cells, all right? Surfactant is produced, which one, help keep alveoli open, and two, it increases the membrane surface area of the alveoli, all right? We need that surfactant to keep it open, or else we're going to have that collapsed balloon theory. Remember talking about that? All right, so airway problems versus breathing problems. I want you guys to start thinking about, we haven't done cardiac yet, but when you're faced with a cardiac problem or whether or not you're faced with a respiratory problem, right, you have to think in your head, you know, it's the cause of one of three things. This is either a diffusion problem, it's a perfusion problem, or it's a ventilation problem, okay? If you feel that your patient is having a primary respiratory problem, one of those three things are going on. This is a problem of ventilation, this is a problem of diffusion, or this is a problem of ventilation, all right? Ventilation. What is ventilation when you're talking about the term of it? What is the definition of ventilation?
Is it manually moving air?
Right, it's the mechanical aspect of it, right? It's the actual process of moving air in and out, right? If I have a 500-pound patient sitting on my chest, that's a problem with ventilation. I physically can't move my chest wall in and out to get a breath in, right? What medical condition would be a problem with ventilation?
COPD.
Mm-hmm.
Is it medical?
Flail chest. I'll take that one. Flail chest, right? It's an actual mechanical problem. You have paradoxical motion. Impeding. Pneumothorax is another one. You have a mechanical process impeding the way that the lungs inflate, deflate, the actual process of moving air in and out, right? How about crush injury, right?
Traumatic asphyxia.
Traumatic asphyxia. That's problems with ventilation, right? Asthma, bronchitis, pneumonia, emphysema. We're going to go over all those. Guillain-Barré or some type of spinal cord injury. We'll go over those in a little bit. And flail chest. All those would be examples of maybe a problem with ventilation, even though there might be some more stuff involved with it as well, right? So, remember that the way that we breathe, right? We breathe on a negative pressure system. In other words, we breathe like a vacuum, right? That's how we breathe. Whenever I breathe in, I am creating a more positive pressure in my thorax, right? And I am now disequalizing the atmosphere from the inside part of my thorax, right?
Are you not? Wouldn't you be equalizing it because you're bringing in the air at the same pressure?
Equalizing it would be when I exhale.
Okay.
Why do you stop exhaling? I mean, there's a couple different factors like baroreceptors and stuff like that, stretch receptors. But one of the reasons why I stop exhaling is because now I'm equalized.
Okay. That makes
All right?
sense.
So no air can move in and out. But once I start this suck, right? I'm sucking in like a vacuum, right? That's how I work on a negative pressure. That's why we call it PPV, right? That's why we call it positive pressure ventilation when we're bagging somebody, because the patient is no longer sucking air in. We are now blowing air in,
Gotcha.
which is positive pressure ventilation, not negative pressure ventilation. So I would normally work on negative pressure. When I gave them a bag, I'm now using positive pressure, blowing air in now. Right? In EMT school, you probably receive questions like this, and in paramedic school, it's not going to be any different. You got to think, because it's it's a little bit confusing, that when I inhale, you got to imagine the lungs expanding. So what is my diaphragm doing?
Going down.
It's going down. But is it contracting or is it relaxing? It's contracting. Okay. So if you get a question like that, on inhalation, the diaphragm contracts and moves downward, right? On exhalation, which is a passive process, your lungs are actually deflating, the diaphragm's moving upwards, and it is what? What's the term? It's relaxing, right? So don't get that confused on an exam. Keep that in mind. All right? Respiration, process by which O2 is taken into the body, distributed and used by the cells to make energy. So don't get that term confused with ventilation. Ventilation is the actual mechanical process of moving air in and out, right? Respiration is at the cellular level, right? So another way that you could say respiration would be cellular respiration. That's the actual process of O2 and CO2 being exchanged at the alveolar capillary network. All right? It's used by the cells to make energy. Remember, we need O2. Sugar needs O2 to enter the Krebs cycle. Without it, we get into a form of anaerobic metabolism in which the body resolves to using solely glycolysis for energy. All right? The body can't do that too well. Remember, from back in patho, one sugar molecule yields about 36 molecules of ATP when put into the Krebs cycle. One molecule of sugar will yield about 2 ATP molecules when used directly for energy within the cell. It's a very insufficient way to make energy in the body. All right?
So would it be safe to say respiration is moving O2 and CO2 exchange or no?
I'll take that.
Okay.
I take that. All right. As long as you know that ventilation is moving air in and out,
yep.
Respiration is the O2 CO2 exchange at the alveoli capillary network. It's happening down here, not out here.
Okay.
All right. And the removal of CO2 of the body or from the body. Right. That's a byproduct of cellular metabolism. So once that O2 gets the sugar to enter the Krebs cycle and it forms ATP, that formation of ATP is going to kick out 2 byproducts. What are those?
Carbon dioxide.
Carbon dioxide and water. All right? Carbon dioxide and water. And if you remember from the patho chapter, I forget what your book says, but it's like 10 to 14% of all the water intake within my body is actually intake from the actual process of cellular respiration itself. Right? So it kicks out water, that goes into circulation, and it kicks out CO2, carbon dioxide. It attaches itself to red blood cells in the form of carbonic acid taken to my lungs, in which the gradient difference between CO2 and blood returning to my lungs is greatly different from the CO2 level that I'm breathing in. So therefore that creates a gradient, diffusion happens, and I blow out the CO2. Does that make sense to everybody? All right? That's key in all of respiratory.
Now, isn't your carbon dioxide attached to your hemoglobin molecule will be carboxyhemoglobin? Is that
correct?
Okay.
Yep. That's absolutely correct. All right. Now, some schools, some books, some trains of thought use a systems approach when you're talking about respiratory emergencies, which is fine. You can do that. All right. If you use a systems approach, then that's what it's saying. You're assessing each system at one time. So when you're assessing neurological status, you have to think of a whole bunch of things, what could be going on. Of course, we're looking at brain. Is this a traumatic injury? Are we looking at a brain trauma, right? How is my patient presenting? Are they aphasic? Are they dysarthric, right? Do they have hemiplegia? Are they just completely paralyzed? Do they have flaccid paralysis? Do they have any focal findings, right? And when I say focal findings, I'm saying, do they have some part of their body that's not being utilized the way that you would expect it to? Do they have facial droop, right? Facial droop. What's that called? What's facial droop called? What's droop called? Palsy, right? Do they have facial palsy? That is a focal finding, right? Or do they have an eyelid droop? That's a focal finding. Do they have, huh?
You said palsy, so it's like cerebral palsy or cerebral palsy?
It's not the same thing, but
Okay.
the term is
Droopy.
droopy.
Okay.
Right. And, so you look for those things. You look for your focal deficits, right? Is it that? Is it a drug overdose? This is when you're assessing your scene, looking for the empty bottles, looking for the know-it-all bystander to give you an idea of this patient has an addiction problem. And spinal cord injury, again, looking for focal findings. When you start doing your systems approach, you get past neurologic status, and we're doing our AVPU, we're doing our GCS scores, and we're getting past that, we're doing cardiovascular status. Mild hypoxia results in increased heart rates, right? That is true. That is not true for kids, all right? Hypoxia in kids will lead to what?
Hypoxia? Oh, well, lead to a cardiac issue.
Well, yeah.
Sensory muscle use.
Well, yeah.
Cardiac issue.
Yeah. But I mean, mild hypoxia results in increased heart rate in adults. It decreased, right? With kids, they get bradycardic
Yeah.
really quick, right? So that's why the number one treatment for kids who present bradycardia is what? O2, all right? O2, and we wait to see if the kid is responsive to the O2 before we start pushing drugs, before we start doing CPR, depending on the rate, of course. But adults will have this increase in heart rate. Severe hypoxia in adults results in bradycardia, all right? So if you go on scene to somebody who's got an O2 sat in 50s and 60s, right? They look like a Smurf, and their heart rate is in the 30s and 40s, you're already one behind the 8 ball. Granted that that bradycardia is due to the hypoxia, not something else, all right? So we got to jump on those people. We got to jump on those people fast, all right? So if you have not remembered the blood flow through the heart by now, I suggest you get on it, all right? Memorize the blood flow through the heart. Not only that, remember the blood flow through the heart, the oxygen-CO2 exchange through the lungs, the way it goes back to the heart, and the way it gets distributed out throughout the body. Okay? Taking it back to AMP.
I got a question, Chris.
Yes.
I've been meaning to ask you, but we had a patient yesterday, and his heart rate was in the 130s. He has difficulty breathing. He has severe, I can't think of the damn word. He's got, he had cancer in the lungs. One of his lungs removed. He had swelling in his legs that were secreting out. His heart rate was in the 130s. Now, when I went with Tishner and Chris West yesterday, they said that, well, obviously you can't give him, his blood pressure was bottoming out, like 180 was the systolic, over like 40. He was going even lower as we were transporting him.
So his systolic was 180 and his diastolic
No, it was 80.
Oh, 80. Okay.
It was 80. And his O2 stat was at 88.
Mm-hmm.
So I asked him, I said, you don't want to treat him with fluid being, normal saline? They said no because it's not an overload. The next option would have been dopamine. But they didn't want to give dopamine because his heart rate was so high.
It's hard to feel.
So it was like, what they did was they just transported O2 and steel, like cold steel, but
well,
if it got worse,
there's a lot of things going on that patient.
Yeah.
Obviously, he's a chronically ill patient,
yeah,
and he's going to be getting the $1 million workup when he goes to the hospital.
yeah.
Who knows? The statement, don't give him fluid because it's not fluid overload.
Well, no, because he was already secreting out of his legs from the edema. Edema, yeah. The
Right.
edema secreting out of his legs. So that was one issue. At the other time, too, with his heart rate being as high as it was, he has a history of CHF, already having fluid on the lungs, having one of the lows.
Did he have rails?
Yeah, absolutely.
Okay, then that would be it.
Absolutely,
That would be
yeah.
no fluid.
So he has a history of that and then lung cancer as well.
Right.
So, I mean, he's up shit creek, no paddle, no doubt. But, I mean, they said they didn't want to give him fluid, but I remember we had talked about dopamine. So I asked him, I was like, would you want to give dopamine at the beta effect here? And they said, well, that's a good option. But with him being so tachycardic at like 130, 140, they were kind of like iffy on that one.
Well,
Is there another? My question to you was there another option that we didn't see?
well, of course there's other options.
Okay.
We don't have them, though.
Okay.
We don't have drugs in our truck that, will increase blood pressure without causing a reflex tachycardia.
Okay.
All right.
Okay.
Now, could you maybe theoretically start dopamine at an alpha dose to cause squeeze and cause pressure to go up without causing an increased heart rate? Sure.
Okay.
All right. And you could do a trial. All right.
Okay.
But I don't see dopamine, putting you into an SVT, if that's what they were worried about. This guy's probably tachycardic to deal with the blood pressure as a compensatory mechanism.
That's what Chris West was talking about. He was like,
But did he have a fever? Did he feel warm?
No.
Did he feel cool?
Normal.
Because the patient might be septic.
Yeah.
It might have been a septic patient. But part of the guidelines of being, septic is not only having an elevated temperature, but you could also have a decreased temperature in sepsis, less than 96. So without a temperature, it's hard to play couch quarterback on a call like that.
Well, my question to you was there another option that we could have done that we didn't see at the time that we had on truck?
It's hard for me to answer that question.
Oh, I'm sorry.
I don't want to steer you wrong
Okay.
without seeing the patient.
Okay.
From what it sounds like, no.
Okay.
From what it sounds like, no. I mean, what else could you have done?
Yeah, I was asking.
Could you have done CPAP? No, because his blood pressure was too low.
And he forgot to take his Lasix that morning as well.
Right. Would you want to give Lasix to a blood pressure of 80 systolic? No, because you're going to decrease that. What the guy probably needs is an inotrope. All right.
Okay.
He would probably need a little bit of fluid with an inotrope to increase his pressure.
Okay.
But we don't have dobutamine on our trucks. We don't have a whole bunch of stuff on our trucks to increase that pressure, without causing that reflex tachycardia that we don't want, especially with a heart rate in the 130s. But why is his heart rate in the 130s? Is he hypoxic? Right? Maybe he's hypoxic and his heart rate's going to the 130s. Maybe he's hypotensive 80 over 40, but a heart rate of 130 with a blood pressure of 80 over 40,
Starting at 88.
starting at 88, doesn't seem, 130 seems a little high.
It was.
For a reflex tachycardia with a blood pressure of 80 over 40. So maybe it wasn't. Maybe it's a primary tachycardia due to some pathophysiology. Who knows? We can what if this call all day long.
Okay.
But without workup.
Well, I figured since we're talking about respiratory now, that kind of kicked in. Like we thought maybe the respiratory drive could have been causing the heart rate to increase, but it didn't make sense why the blood pressure would drop. It's not your telltale sign.
Yeah, and also it could be multifaceted too.
Okay.
He could have more than one problem going on too. Who knows?
Add valves.
Huh?
Add heart valves.
Could be anything, man. Without a full history, without a full workup, without a full H&P, without EKG in front of me, without lab values in front of me, without everything, it's really hard to actually pinpoint what's wrong.
Yeah.
As far as EMS and in emergency medicine in general, we treat the life threats. What is going to kill this guy right now, right? His heart rate of 130 is not going to kill him right now. A blood pressure of 80 over 40 is not going to kill him right now, right? That's a decent map. 40 is a little low, but still, it's a map over 65. We can go on with our day. Deliver our patient in equal than or better than condition when found, and do a follow-up. See what's wrong to make the call better for you next time. Anyway. All right. So muscles and mechanics. Asthma patients compensate. All patients compensate, right? Remember, at the very beginning of class, devoted energy to breathing, right? Almost 50% of your complete cardiac output is given towards the respiratory process, right? Almost all of your cardiac, almost half of your cardiac output is needed just to deliver your respiratory response, to deliver respiratory adequacy, right? That's important. And a lot of energy is delivered to somebody who's having trouble breathing. Anybody here ever seen somebody in a real bad asthma attack? Right? I mean, they are huffing, puffing, they're anxious, they're flailing around. They look like hell. They look like they're dying, right? The example I always give is just try to maybe run 3 miles and breathe through a straw, right? And see how you feel, right? After a while, you're going to take that straw, pull it out of your mouth, and you're going to be like, oh my God, that sucked. But these asthma patients can't. So you can only imagine the anxiety felt, with this. Firemen can kind of relate to it. When we did the Fire Academy, we did the roundup, right? When you worked on a bottle and you worked to see how long you could work on that bottle, and when you started running out of air, you still worked until you're breathing. The mask is sucking into your face, and what's the first thing that you do?
You want to grab it and rip it.
You grab the mask and you rip it off your face, all right? Well, these asthma patients can't grab the mask and rip it off their face, right? So it's a very anxious thing, a lot of energy being utilized, right? So they tire and they compensate. You'll see your asthma patients, they actually start to bob their head. They look like they're falling asleep. But they essentially are. They're going unconscious on you, right? They're going into type 1, type 2 respiratory failure, right? They're going probably into a hypoxic respiratory failure or an elevated CO2 respiratory failure, type 2 respiratory failure, all right? Sitting position when short of breath, right? These patients are going to sit the way that makes them feel most comfortable, right? And usually, when they're flailing around, thrashing around, and they're sitting on your stretcher, you'll see them, they'll sit up, they'll put their legs on the ground, and they'll straddle the stretcher because they're not laying back, all right? If you have a really bad asthma patient who willingly lays back, that's a bad sign, all right? That's a really bad sign, all right? Now we're assessing kidneys. Well, fluid balance, it's kind of hard to assess fluid balance, Yeah, we're looking at edema. Yeah, we're listening for rails, but we don't do Foley's in the field. All right, we can't assess for urinary output.
But you can ask them, when's the last time you urinated? Or what did it look like?
You could,
Or how often have you been?
Right. But there's also a classic saying, in medicine, if you ask a question, know what you're looking for. You know what I'm saying? Okay, what did your urine look like? I tell you it was cloudy and you couldn't see through it. What are you going to do with the information, right? If you're going to ask that question, know what you're going to do with the information, right? I mean, as far as we're concerned, if we ask a question like that, then we're just going to pass it off onto the nurse. the majority of medics aren't going to be thinking, okay, well maybe there's like excess epithelial cells making it cloudy, or maybe there's proteinuria making it cloudy, or maybe there's a bacterial infection making it cloudy. Because generally paramedics don't care. Because regardless of the answer to that question, we're not going to do anything. So paramedics don't ask it. But is it a good question to ask? Sure. You know, if you're assessing renal status, you know. On trauma patients or any other type of patient, you know, if the patient says something that's like detrimental, you know, I'm peeing blood, or it looks like tea, like brewed tea, you know, then yeah, you know, that could be a rhabdomyolysis or a myoglobinuria condition or some type of crush injury. Those are important questions to ask. Just if you start asking questions and the patient gives you an answer, know what to do with the information that they give you. Does that kind of make sense? It's hard to check acid-base balance. We went over acid-base and ABGs a couple weeks ago. But we don't do bedside eye stats in the field. Some ambulances might, all right? But if you get an acid-base back and you notice that your patient is respiratory acidosis, right? What's the number one cause of respiratory acidosis?
What's the number one cause of respiratory?
Yeah, respiratory acidosis. Failure to ventilate, right? Hypoventilation. And on the flip side of that, what's the number one cause of respiratory alkalosis? Overventilation. Hyperventilation, right? Checking blood pressure. All right? Danny, read it for me.
You and your partner are dispatched to the private residence of an 87-year-old in respiratory distress. You arrive on scene to find a woman who is in a tripod position and appears to be in moderate respiratory distress. She is conscious, alert, and speaking in 3 to 4 word sentences.
All right, so she's 87 years old, which means she probably has a plethora of medical conditions. She's conscious and alert, which is good, but speaking in 3 to 4 word sentences, that's not good, is it? All right? That's a nice sign of acute dyspnea, that we have to figure out what the hell is going on. So, our initial assessment, remember, body types, these are,
Sorry.
we'll assess her later.
Alright. I think I need a cigarette.
These are classic test questions here, right? Emphysema patients. The classic presentation of your emphysema patient, right? Barrel chest, muscle wasting, pursed lips. Or if I'm Van, I say purged lips. Damn lips are purged, yeah, because they're purging. They're purging. I hate you, Chris. Barrel chest, right? We see these COPD patients, they got this really big chest, kind of barrels out. Why is their chest barreled?
Fluid.
No.
Overexpand it to compensate.
Okay, that's one theory. Overexpanding of the accessory muscles, right? Creating kind of almost, you know, a hypertrophic problem. The main reason why is because of air trapping, right? Air trapping. Air is being trapped because COPD, which is emphysema, is primarily an inspiratory or an expiratory condition. What's the problem? Is it a problem with inspiratory or expiratory? Expiratory, right? Test question, Respiratory 101. COPD is an expiratory problem. Right? These patients can't adequately get air out. Right? These patients have an abnormally prolonged, what they call expiratory phase. We see that on our ventilators. Right? We see an IE ratio, or inspiratory to expiratory ratio. A normal IE ratio, like for us, would be 1 to 2 seconds, or 1 to 3 seconds, right? Meaning I breathe in for 1 second, and I exhale for 2. So if you have a test question, which is longer, your inspiratory or expiratory phase, what would be your answer? Your expiratory phase would be longer, right? On these COPD patients, they have a prolonged expiratory phase, right? You're looking 1 to 3, 1 to 4, maybe even 1 to 5 seconds, meaning that they breathe in for 1, and they have an exhalation phase that lasts for about 4 to 5 seconds. All right? So you have this trapped air creating barrel chest, and they have pursed lip breathing. Well, what is the pursed lip breathing for? Why is the COPD patient doing that? Open up the alveoli. I like it. And what's the term we use for that?
Atelectasis.
Atelectasis?
Yeah.
Okay, I take that. What else? What's the respiratory term that the body does in order to try to keep alveoli open?
I was going to say increased surface area.
Okay, you're all on the same page, right? Lacking of surfactant causes collapsed alveoli, which is atelectasis. Atelectasis causes the decrease in alveolar surface membrane area.
What was your question? Maybe
What is the medical term for keeping the alveoli blown up by using pursed lips? What am I creating?
Positive pressure, back pressure, positive back pressure.
Okay.
Blow it in the back, same concept. I don't know the exact term, but I know where you're at.
You're on the right track, right? They're the sounds that little chickens make.
Sorry.
Sure.
Chirp.
Peep.
Peep. Come on, man.
Peeps are what you eat for Easter.
Yeah, that would have given it away, though. Peep. Peep. Now, we all have an auto peep, they call it, right? All of us have this built-in automatic peep that we all use on a day-to-day basis, right? So when atelectasis is happening due to alveolar destruction, as Melissa is showing us, reminding me why I need to stop smoking, then alveoli collapse, right? Atelectasis ensues. So when that happens, my body tends to purse the lips, right? It's a compensatory response that I don't even have to think about. We all do it. Like, we've all taken a deep breath before, and we're like, all right? We just do it because that's my brain saying, hey, I need to increase PEEP, which is positive and expiratory pressure, right? I'm creating this back pressure, my alveoli go, boop, right? Increases the surface area for oxygen CO2 exchange. It's great. That's what causes the pursed lip breathing, right? So if you combine the barrel chest with the pursed lips, we call these people pink puffers, right? They are pink puffers. But why is my COPD patient pink?
Because they're getting oxygen to the capillary bed, so they're not showing blue. They're passing oxygen through. They're just not able to get rid of their overabundance of CO2. It's not an oxygen problem.
Okay.
Lack of oxygen problem. It's an over CO2 problem.
All right. So these patients are in a chronic state of respiratory acidosis.
Yes.
I like it.
There we go.
But why are they really pink? No. What causes pink color? Well, except for in you.
Blood.
Skin.
Huh?
Looking at the skin surface.
The pigment, right? The pigment of blood causes the pink color. So if red blood cells cause pink color, and these COPD patients are really pink, what do they have a lot of? Red blood cells.
Oh.
Right? The body compensates, right? They're in a chronic state of hypoxia. So, and when I say COPD patient, I'm really meaning emphysema. I apologize for that inaccurate synonym, right? But my COPD patients, or emphysema patients, they're chronically hypoxic, so they produce more red blood cells. They produce more red blood cells to try to combat this chronic hypoxia, right? And now they are in a state of polycythemia, which is the increase in red blood cells, right? So if you make a COPD patient polycythemic with pursed lip breathing, then they get the pink puffer name because they're pink and they're puffing, right? Or you could say they're also puffing on a cigarette, however way you want to look at it. So in contrast, your chronic bronchitis patients, those are going to be your blue bloaters, right? So we got pink puffer, we have blue bloaters. Chronic bronchitis patients tend to be obese. This tends to be almost like a Pickwickian syndrome type response of being obese and having respiratory distress. But chronic bronchitis is more towards a increased amount of mucus, all right? An increased amount of mucus production. Not so much of an alveolar destruction problem like COPD is. I mean, there's a plethora of other problems that COPD creates. But bronchitis is more of a hypoxic problem and mucus production problem. So these patients are going to be blue bloaters, pink puffers. All right? Remember that. What position is this called?
Tripod.
Tripoding. They are trying to, extend everything, make everything nice to decrease the airway resistance, right? I mean, we've all sat like that on the toilet, right? When we have a hard time pooping, we try to straighten everything out, it comes out nice, right? It's the same concept. The same exact concept. So if you notice that your patient is sitting there tripoding, that's a bad sign. Purposeful hyperextension, right? They're trying to increase those three axes that we look for when we're intubating somebody, but they're trying to do it naturally to try to get as much air in as possible. You know? So in lab today, when we're talking about, you know, assessing your dyspneic patient, or when you go on calls, and this is something that we can start from the door, right? Right when you walk in. In the lab, we have to be verbal. But in the real world, when we walk in through this door, this is what we're looking at, right? What muscles are they using, right? Do you see retractions or nasal flaring or tracheal tugging? Those are all bad signs. Do I see paradoxical respiratory movements, which is a good sign of a flail chest? And when I'm walking in, if I notice my patient's neck just like they're flexing their neck every time they're taking a breath in, those are accessory muscles that they need to breathe. That's not a good sign. It's very hard to fake that. What's pulsus paradoxus?
Blood pressure drops when you breathe in, basically.
Right. Blood pressure or pulse, right?
Yeah.
That fluctuates when you breathe in. Minor degrees of changes in pulse when you breathe in are normal because we're changing interthoracic pressure, right? We're changing interthoracic pressure from more positive to more positive to negative. So heart rates are going to fluctuate because the more I breathe in, the deeper breath I take, I'm decreasing preload, right? I'm putting more pressure on vena cava, decreasing preload. Heart rate changes to compensate for the change in preload.
There's a little bit of that vagal response too.
I wouldn't say vagal response. No, I wouldn't say that in that instance. But it all boils down to that blood pressure hierarchy chart that I wrote on the board, right? You put increased pressure on the vena cava, decreasing preload. Preload affects stroke volume. When you decrease stroke volume, what happens to compensate? Heart rate changes to compensate for that, all right? So, but normal degrees of that, I mean, slight changes in that's normal. It's when the patient starts like, you know, having changes of 10 to 20, right?
Did you say when you breathe in, the pressure
Increases.
decreases?
Decreases.
Yeah, it's not
Decreases.
increase.
Preload decreases, decreasing blood pressure, increasing pulse rate.
Preload increases because you're decreasing intrathoracic pressure and allowing more blood to flow in.
Think about this. Why don't we bag people? What's the train of thought in bagging people? You should know this from working in Hillsborough County with this whole circle crap that's going on, right? When you intubate somebody and you bag somebody, if you bag them at high tidal volumes, why don't we do that anymore?
Because you're worried about circulation of the oxygen or the molecules around the blood. You're not worried about respiration as much because respiration is a natural motion as you do chest compressions.
Right.
Your body's actually inflating the lungs, so to speak. So you're worried about circulatory more than you are respirations.
I'll take that. But they also notice that when you intubate somebody and you're bagging them at high tidal volumes, you're increasing interthoracic pressure by giving positive pressure. Now, if you increase lung expansion, right? You're increasing lung expansion. You're increasing interthoracic, pressure. Then you're going to decrease preload.
You're lacking the ability for the heart to actually constrict and move like it needs to.
Correct.
Too much
So that's one of the
pressure
things, right? You're decreasing coronary perfusion pressure. But you're also decreasing preload. You're putting pressure on the vena cava, decreasing the amount of blood that actually returns to the circuit, right?
I got a totally different podcast. It was Jeffrey Guy, totally against that.
Well, show it to me.
I will.
Yeah, show it to me. It's, that's the theory behind it. Giving lower tidal volumes.
I had my iPod outside.
Jeffrey Guy knows his stuff. I'll argue with
do
him.
all the work. Just
Right. So we already talked about IE ratios or inspiratory-expiratory ratios, right? We already talked about that. Respiratory nodes are audible with the stethoscope are abnormal. So when we say abnormal respiratory sounds, we say adventitious sounds, right? So on a test, if you see adventitious, you're thinking that those are abnormal. Quiet chest is not good, right? We're listening for lung sounds, we hear nothing. Could be hyperventilating. They could be hyperventilating so fast that their tidal volume is so decreased that they're not getting any air in, right? Acidosis or shock, right? Now, let's see if I can there we go.
now let me ask you this though: if you're hyperventilating, let's say you have a patient that's hyperventilating,
Yes.
would instead of knocking them down, taking over the respiratory drive of the respiratory, wouldn't a bag, VVM, do suffice Was it thinking of possibly intubating them?
Absolutely.
Okay.
Yeah, multiple studies have shown that using the BVM in the short term is just as effective as an endotracheal tube.
Okay.
Yeah, absolutely. Mhm.
So if you can't control it BVM wise, you're thinking about taking it over completely
Correct.
because they are.
Right.
Okay.
Yep. And sometimes a BVM is all you need, right? We take over Airway with an endotracheal tube, and that's our last ditch effort.
Okay.
Right? And if we can't, if that's our last ditch effort, and we can't intubate them, then our last ditch effort would be cut the throat. Right? But you remember, failure to intubate never killed anybody. It's failure to ventilate which does. So always, keep in mind that your BVM is your best friend. So this chart here, know it, love it, learn it, because this is the EKG of the respiratory system. All right? You're going to get test questions that talk about these different types of respiratory patterns. All right? So agonal. Agonal, we all know that it's the fish out of water, right? It's, short, gasping breaths, very, very bradypneic. All right? As far as apneustic, what you should know is prolonged inspiratory hold, or kind of fish breathing with a prolonged inspiratory phase. Ominous sign of severe brain injury. Another one you're going to see a lot on a test is Kussmaul's. Right? Kussmaul's. If you think about it, the same pattern as central neurogenic hyperventilation, but caused in response to metabolic acidosis. Then you think of the conditions that cause metabolic acidosis. The book will classically tell you that DKA is a cause of metabolic acidosis. And it is. It's a cause of anion gap or large anion gap metabolic acidosis, right? These patients are going to be presenting with a fast respiratory rate that's going to be sort of irregular. Kussmaul respirations are seen in patients with DKA, right? Fruity acetone breath, which is, depending on what study you read, only present in about 6 to 10% of patients in the first place, right? But these are a form of hyperventilation, deep, fast respirations in an attempt to blow off excess acid. That's the theory, all right?
So your hyperglycemic patients are going to be presented with Kussmaul's.
Not just hyperglycemic. At the true term of it, your DKA patients are going to be.
Diabetic.
Right? They can have a sugar of 300 and not be in DKA.
Okay.
Right?
Gotcha.
But if you're sitting there with a patient with a sugar of 600, and remember, taking all the way back to patho, we're going to do this when we do endocrine. One of the jobs of insulin is to inhibit lipolysis, right? So if I have an absolute decrease of insulin, lipolysis happens. Breakdowns of fats happens, which form ketone bodies. It forms 3 different types of ketone bodies, and one of the ketone bodies it forms is acetone, right? So high levels of acetone are in my blood. I breathe out, and that's what I'm smelling. It's that fruity odor. But again, it's not present in a lot of patients, right? The more and more you read about medicine, the more and more you realize that the classic signs of a disease is only present in like 20% of people, which to me isn't really classic, but that's what they teach. Okay, we know tachypnea. Sighing, right? Why do we sigh?
Because you're bored.
Because you're studying respiratory in paramedic school?
You're like,
Well, that's why we sigh. We sigh because we're blowing up alveoli, right? You're sitting there and you're tired. You're just sitting there relaxing like Danny is right now, right? And then you go, I'm not taking in a lot of tidal volume. And because of that, alveoli tend to start collapsing a little bit. Nothing too bad. It's normal and physiological. But then I sigh to blow those back up.
so what is yawning then?
Yawning, it's cerebral hypoxia.
Okay.
All right. We're tired. Again, we're not getting a lot of tidal volume in. All right. We're just kind of sitting there chilling. We're not taking a lot of air. So the theory behind yawning, I have no idea why it's contagious, But the theory behind yawning is that I'm taking in a deeper breath to increase cerebral circulation. And again, that's a theory. I don't think anybody knows really why we yawn.
I saw something on the History Channel that had something like that.
What, a yawn? Like a theory behind it?
Yeah, it's from a long time ago when people lived in caves to tell everybody to go to sleep at the same time, so because everybody would sleep at different times.
Really?
And it's like some type of subconscious thing that humans developed, so everybody would sleep and wouldn't keep everybody else awake. And it's part of
That's a good
nature.
theory. But how do you pass a sociological behaved trait down?
It's successful. You're just naturally like that, and then you survive. That group of people survives better because they're more rested and better hunters. And well, I mean, that's the theory behind it from a biological standpoint.
Nice. I like it.
What's that?
Yeah.
You have to yawn. All right. Again, back to neurological. What are they? Are they restless? Are they confused, combative, sedated? You got to keep in mind that altered LOC could be a sign of hypoxia based on your differential. Again, whenever you have a patient who's altered LOC, use your AEIOU tips mnemonic to try to decide whether or not your patient is hypoxic. All right. Whether or not this is an overdose condition. Skin color. We know cyanosis is blue discoloration. Are they chocolate brown? All right. If they're chocolate brown, it might be a hemoglobin problem. Right? I think that was on a medical show once, that the patient had chocolate brown skin, and it was methemoglobinemia, all right, which could cause a diffusion type problem or a perfusion type problem, all right. Are they pale? Were you laughing that he's
I'm
methemoglobinemia?
Yeah. I'm like,
That's funny. So our history. Scene say BSI, MOI, NOI, number of patients, digital resource, C-spine. Why did you call? Right? These patients, they might have knowledge of their condition. And in some cases, in the majority of cases, if they have a history of asthma and now they're complaining of DIB, if it looks like a duct, quacks like a duct, it's probably a duct. So it's probably an exacerbation of the asthma, but it's not 100%. You can't hang your hat on that diagnosis based on their history. But history will give us a nice clue about what's going on. Onset duration. So in other words, we're using almost like a modified OPQRST that we would normally use when we're assessing pain. We're kind of using that to figure out what's going on with our respiratory. Rapid onset DIB. Happened right away, right? So if we see a rapid onset DIB, we got to try to figure out what's number one on my differential for rapid onset dyspnea.
Well, first you want to find out what we were doing during the time, because it could be, were they playing sport? Were they not?
No, they said they weren't playing sport. They were kind of just chilling there watching television, and all of a sudden, bang, DIB. Didn't happen gradual, didn't happen overnight, bang, right there. Huh?
What provoked it?
Testing 101. Whenever you see rapid onset DIB, you're thinking one thing until proven otherwise. PE, right? You're thinking PE until proven otherwise, right? So that has to go into your differential. These questions are important. They're going to kind of guide you into the right direction that you think you need to go, all right, based on what your differential is. Paroxysmal nocturnal dyspnea. On a test question, when you see paroxysmal nocturnal dyspnea, you're thinking one thing until proven otherwise. What?
Doc still what?
Nocturnal dyspnea, I'll go over that in a minute. But you're thinking CHF, right?
What does that mean?
Paroxysmal, it happened quick. Nocturnal, it happened at night. Dyspnea, they're having trouble breathing. In other words, this DIB woke them up out of sleep. All right? You get called at 4 in the morning, they're huffing and puffing.
Apnea, so to speak.
Well, not so much sleep apnea, but I mean, sleep apnea you'll wake up like groggy and stuff like that, Paroxysmal nocturnal dyspnea, they're sleeping and they wake up and they're huffing and puffing, right? So your question to them is, did you wake up and start having the trouble breathing? Or did the trouble breathing wake you up, right? If the trouble breathing woke them up, you're thinking CHF until proven otherwise, right? That's one of the most classic signs of CHF, right? What is their position of comfort? We know that question, right? Did this ever happen before, right? And associated symptoms, attempts to treat, all those are important. If your asthma patient is huffing and puffing away and you're like, have you ever had to be intubated before? And they say, yeah. That patient's a little critical, right? Because they got bad asthma. They've had to be intubated before. So that's going to help you guide the treatment for your patient. Neck exam. We're looking at trachea, we're looking at JVD. Now, we're not doing a rapid, trauma assessment that we would on a trauma patient. We're doing a medical head to toe, right? We're taking a glance, we're looking at the patient, we're putting our hands on the patient. And we're looking at their neck. That can tell us a lot, right? The tracheal could be tugging. That could tell us what?
The trachea.
Tugging.
It's moving back and forth as they're breathing.
That could be a pneumo, type of spontaneous pneumo.
No. Tracheal tugging,
Oh.
not deviation.
Go back and forth.
Every time they breathe, it's like,
It's
Yeah.
retraction.
it's a
Breathing
retraction.
hard.
It's an accessory muscle use, right?
Okay.
There's signs and symptoms. What's the difference between a sign and a symptom?
Signs what you can see, what they tell you.
Right. In other words, patients can't lie about signs, right? And I'm not saying lie, right? You could be like, oh my God, my pain's 10 out of 10. And they're just kind of sitting there. Whatever. You're using it as a guide. You're not saying that, oh my God, they're in the worst pain that they've ever had in their life. You're using it as a guide of your treatment, right? What's their 10? They could be saying, oh my God, I'm having so much trouble breathing. It's like insane. It's like 10 out of 10. It's crazy, you know? But they're tracheal tugging. They can't fake that. You know what I'm saying? So we utilize our signs. And if you see tracheal tugging, then that could be a good sign that they're not lying. JVD. Why do we look at JVD? What are some things that can cause JVD?
CHF.
Okay, CHF can cause it. What else? Globalize it. Dumb it down.
It's back up. Basically, the JVD deviation is back up a blood flow to from the brain. So it's the veins backing up. So your preloads drop. It's all in your heart, which will affect your respiratory.
You're almost right.
Okay.
Almost right. Follow the pathway, right? What do the jugulars do, right? It drains blood from the brain,
Yes.
right? The jugular drains into where?
Subclavian.
The subclavians,
Yeah, subclavian.
right? So anything that causes a backup this way, maybe not this way, right? There's not a lot of blood up here, right? Adults can't go into hypovolemia by hiding blood in their head. Kids can, right? But adults can't, right? So if I'm bleeding in my head, it's really hard to cause a backup and cause JVD. Could it technically happen? Sure. But if the blood being pumped out of my right heart isn't being pumped effectively, where's it going to go? It's going to back up via cava, subclavian, jugular, right? So globally, anything that causes right heart failure, right, or the right heart isn't pumping effectively can cause JVD. So then we think, what is associated with right heart failure? Lungs, COPD, tamponade, CHF, pneumothorax. Anything that's affecting cardiac output can cause JVD, right? So we're looking at that. Liver failure can cause JVD, right?
How could that?
How can liver failure?
Because of the.
Remember talking about the hepatic portal system?
Mm-hmm. But that's a lot of backup.
That's a lot of backup, right? Mm-hmm. It's part of that whole hepatojugular response, in which you put a closed fist on the liver, right? Have the patient breathe, and if I see JVD when I do that, that's signifying a backup in the hepatic portal system, right? I'm preventing it, and that's a good sign of liver failure.
It's a long time.
Oh, there it is right there. Hepatojugular reflex, right? Vibrations, right? When I'm listening to the chest and I'm looking at the abdomen, do I feel or hear vibrations in the chest? Could be a sign of fluid. Examine the extremities, edema, right? Edema of the ankles or lower back. We call that sacral edema, right? Do they have edema in their sacrum, or do they have edema in their wrist and ankles? If I have edema in the periphery, I am thinking right heart failure. If I have edema in my lungs, I am thinking left heart failure, right? It all depends on where it backs up, right? So using our stethoscope, right? We all have stethoscopes, and they both have two sides, right? A small side and a big side, right? Now, the small side, you hear some medics say that that's the pediatric side of the stethoscope, right? You ever hear a medic say that?
No, but I heard you say it's more pronounced listening sound.
Yeah, you hear different sounds. The stethoscope was created for listening for different sounds based on whether or not you're using the bell or whether or not you're using the diaphragm, right? It's not a pediatric side of the stethoscope. Yes, people tend to use it for pediatrics because it's smaller, but it's not a pediatric side, all right? The diaphragm is for high-pitched. The bell is for low-pitched. So the bigger side, high, smaller side, low, all right? Make sense? And you can hear that. And we auscultate. Lungs are not symmetrical, all right? Is that bad? What is going on? I'm listening for all fields. And I'm not saying you need to listen for 12 lung fields in the field, all right? Apices and bases on both sides would be sufficient, right? You don't need to listen for tracheal sounds. You don't need to listen for bronchial sounds. You don't need to listen for middle lobe and middle upper lobe. And you don't need to do all that, right? We need to get a clear-cut picture about what's going on. Sometimes listening for tracheal sounds would be beneficial, right? Because when we're listening for lung sounds, we got to listen through skin, muscle, we got to listen through bone, right? So it's very hard to hear. But I have bronchial smooth muscle in my trachea, don't I? I have beta 2 receptors in my trachea. So I put a stethoscope on the trachea, right? I don't have hardly any resistance here, right? So I can really listen for airflow, right? I mean, if you're listening for lung sounds to see if the patient's moving adequate air, we're better to listen to than the trachea, right? They're very loud. Tracheal sounds are very loud, right? As opposed to here. So listen for your trachea. Sometimes you can hear wheezing in the trachea and not here if I have upper airway inflammation or constriction. So use that to your advantage, right? So we say tracheal, bronchial sounds, right? Bronchial are the smooth, breezy vesicular sounds in the periphery, and we can hear that. And we'll see if you can hear this. Oop, wrong slide. See if you can hear this, and then we'll take a 5-minute break. All right? But if you don't know this website, it's a great website to use, you know, to practice your lung sounds. Right? You hear this lung sound, that's normal. I also like this website because it also shows your IE ratios. Which one's expiratory, which one's inspiratory, which one lasts longer. Exhale. Right. Those are what bronchial sounds sound like. They're very smooth, they're very breezy. You don't hear any wheezing. All right. So this website here, easy auscultation, I like. As opposed to, say, can you hear the gurgling a little bit? It is, right? It's bronchial.
Oh,
It's upper airway, upper airway, but it's wheezes and rhonchi. But you can hear the gurgling a little bit.
And the exhale is extremely low.
Correct, because this patient probably has asthma or bronchitis, and therefore those patients have a what? A prolonged expiratory phase. Right? That's classic. Right? So get to know this website, and it's a great website to use to practice your lung sounds. All right? And with that said, we'll take